In this report, we're going to present a case of an unruptured AVM on a young patient that we chose to use an EmboCure approach using a transvenous route. The most important thing about this case for us is to consider the fact that the reported rate for EmboCure using Onyx varies between 6 to 54% in the literature, and that there is a significant range also in mortality and morbidity and mortality between 6 to 30%. Because of those questions, we actually decided to put together all our series of attempts for EmboCure and analyze on what we call the AVM-ES EmboCure score for onyx embolization of AVMs. And this publication considers basically a scale from 0 to 10 that looks into size, arterial pedicles, the draining veins, and perhaps the most interesting new factor was called vascular eloquence. And this one is basically how you assess the pedicle that you need to catheterize to embolize a malformation, and how much of how dangerous it is to get this pedicle. And this score allows us to then give an assessment to what is the risk to try to attempt EmboCure in an AVM. With that in mind, we proceed to present you a case of a newly diagnosed AVM and a 17-year-old girl that had no symptoms. And as you can see, the draining vein is a deep venous system, and you can appreciate on this MRI the nidus is about 1.5 centimeters, a single arterial feeder, and two draining veins. The vascular eloquence we consider negative or minimal, and then the AVM-ES score was 4. This is the DSA revealing the characteristics just described, and you can appreciate the presence of in the lateral view here now the nidus very compact but complex because of the draining veins coming out on the anterior and posterior aspect of the malformation. And this is the approach that we chose. The first one was a transarterial embolization with onyx, and you can see how complex was to place this microcatheter through the anatomy into this very distal location. There was a consideration for surgery also, but due to initial presentation being no symptoms, we decided to go ahead and proceed with an embolization. As you can see here, a very good penetration in the first treatment, and we were quite satisfied with our embolization. This is the original angiogram showing a what looks like a complete occlusion of the malformation on angiography. Because of this very complete embolization, we always recommend our patients to undergo a special protocol post-prolonged intranidal embolization, and this protocol involves maintaining the patient intubated until at least you obtain an MRI and MRA postoperatively showing complete occlusion of the malformation. We also keep the blood pressure in a very tight control. The use of mannitol, decadron, anticonvulsants, and actually very importantly to use antiemetics for 24 hours due to the concerns with the changes we have in flow caused by such a embolization. We also have a very special imaging embolization, post-embolization protocol that involves an angiogram at 6 months with an MRI and MRA, and this is not only the acute phase you assess with angiogram and MRI, MRA, but at 6 months, and then after that, in a yearly basis with MRI and MRA. In this case in particular, the 6-month follow-up revealed a bit of a surprise for us. There's a feeling, an early filling vein. You can appreciate more now in the lateral view that there's an early filling vein. And because of that, we had a good occlusion of the anterior portion of the nidus. So we felt that we had to discuss the options of go ahead and do a direct surgical resection radial surgery, or further embolization either from arterial or venous approach. And this is a difficult discussion, but because of the way the anatomy is now, you can see that the draining vein has a much easier ability to evaluate in the anatomy of the angiogram than the arterial route. Because of that, we decided to go with the venous approach and using embolization. The arterial approach here will carry a significant amount of difficulty due to previous onyx cast and difficulty to locate the position of the microcatheter in the nidus. So we do find that when you have a single venous drainage with a previous arterial embolization, it offers an ideal situation for a venous approach. And this is what we decide to do with in this case. The preparation for the second session and the transvenous onyx embolization involves a number of decisions. One is that you have to, in this case, we chose to go with the Echelon 10 microcatheter and a Synchro 14 microwire. We did not use an intermediate catheter. If one needs more support, this is a very reasonable access to have an intermediate catheter placed into the certainly transverse sinus, sometimes even at the straight sinus level. Here you can appreciate that the Echelon 10 did a very good job in catheterization of from the transverse sinus into the straight sinus and back into the deep venous system into the nidus of the AVM in a retrograde fashion. You can see the beginning of the embolization now. We here are trying to create an initial plug, and fortunately enough, the initial embolization is actually going into the nidus, as you can appreciate. But as you do this embolization, we try to minimize as much the reflux into the normal cortical veins or deep venous system. The main issue here is that we had the option to potentially use two microcatheters and use a pressure cooker like technique, which is use two different types of either an acrylic and a proximal catheter. In this case here, you can appreciate that the reflux is happening. So you can see in the video below that we stop the pause and do an angiogram to assess our embolization. But the main thing here is to really be very careful not to allow much more reflux than the plug. If you did a pressure cooker technique, one would have a plug that would limit and control that reflux. Another option is to go with a dual lumen balloon. If you're able to navigate this into this location, then you also have to you can have the control of flow by inflating the balloon as you are embolizing. Here you can see that we're able to control very well the portion of the nidus I was feeling. There's no more early feeling vein. And the importance here too is to be very careful with minimal reflux. One then can pull the microcatheter without having problems with injury to the vessel anatomy. A detachment catheter or a detachable tip catheter may be helpful in these situations. Here, we're many times when we feel that we have a complete embolization, we tend to inject a little bit more onyx beyond that, so that it fills the vessel completely, so that you don't have any type of layering effect when you have just not a complete filling of the blood vessel. And in this case, it's actually very helpful when you think you're completely done to do a little further embolization. As long as it stay within the domain of the previous cast, it will be safe and also provide a more complete embolization. So here we just looks like we're pulling the microcatheter out, and I will do a run to confirm our position. And in this case, looks like we have a complete occlusion of the malformation. So this is an approach that was ideal for the situation. We monitor blood pressure, as you can see in the screen, and it looked like it was a procedure that was a total of about a little bit over 45 minutes, and were able to embolize the remaining portion of the malformation. This is now the follow-up in 8 months MRI. It's a little bit over the 6 months that I mentioned earlier, but it shows that the malformation is being completely eliminated, and that the brain surrounding the malformation also has no evidence of any significant ischemia or strokes. So we're very pleased with this result. A discussion is important, as I mentioned to you in the study, that when we review our experience, the rate of the AVM ES grade 4, the rate of chances of having a complete embolization without having complications is in the range between 60 to 70%. And if you look at the chance of having a complication embolization, it would turn out to be around 8%. I think these are numbers that are important for us to have in mind when we counsel our patients on the risk of having a treatment done, especially with the embolization. In this case, this applies mostly for onyx liquid embolics, we also have had very different experience than has been published in the literature regarding the effects of a rupture AVM. So I think that not only is the complication from the treatment or the attempt for embolization depending on the grade of the malformation, but also what has been reported that a rupture AVM in the previous experience did not cause significant change in mortality or MRS score. In our experience, that has not been the case. We have had a significant mortality on initial hemorrhage of AVMs, as well as a significant change in quality of life. So I think that these numbers speak for itself and make us a little more concerned of unruptured AVMs having a worse impact on their initial bleeding than what has been previously reported. With that, I would like to end this presentation. I'd like to thank my team, especially Dr. Okada, for helping us to present this technique that it can be extremely helpful in a situation just like the one reviewed in this video. Thank you.